Hey guys, this is Dr. Charity Stanley, and today we're talking about advanced respiratory conditions. So this is going to encompass everything from pneumonia to ARDS. So it's going to be stuff that you see every day on our general med surg floor, all the way to one of the most dangerous conditions that threatens your patient's life, which is ARDS. Okay, so first off, we're going to be talking about pneumonia. With pneumonia can be caused by a variety of different things. It can be caused by viruses, viral pneumonia. It can be bacterial pneumonia. Mycobacteria is specifically a classification called walking pneumonia, and it tends to have very high fevers that's associated with it, and you feel really bad, but in general, you don't have to be hospitalized for it. Now, fungal pneumonia is one of the most dangerous because with anything that's caused by a fungus, we have to treat it with amphotericin. And one way to think of amphotericin is by a nickname that I've given it, amphoterrible. Because what happens with amphoterrible is lots of terrible, terrible side effects that happens with it. Your patient, when you do a chest x-ray, it will show consolidation. What that means in common English is that you're going to see a whole bunch of white where there shouldn't be white. That white is due to thickening of the lung tissue and also due to mucus that's present in the lungs. So what are some of the interventions that we would include for our pneumonia patients? So there's several of those. First off, we've got to give them oxygen. Even if a patient has existing COPD, you would still want to give them oxygen. You never deny oxygen to a patient that needs it. There's different ways that we can give people oxygen. If we're just needing to give a small amount of oxygen, we would use a nasal cannula. Then we can also do a simple face mask. Nasal cannula is typically 1 to 5 liters. A simple face mask is going to be 6 to 10 liters. And then we also have non-rebreather masks that can deliver 100% oxygen. However, if my patient is not able to breathe deeply or force that air in, then the non-rebreather mask really isn't doing any good. So from there, we will move on to BiPAP and other interventions. So we also can teach them how to cough. So with coughing techniques, we want them to take a deep breath and then cough as deeply as they can. Chest physiotherapy, I could be using something that vibrates to help break up the mucus in the lungs. We could also do positional changes. You're very commonly heard of now, since COVID, putting the patient in different positions with the rotoprone beds to be able to change the direction of where the sputum consolidates in the lungs. Now, we say cautiously hydrate. The reason for that is if we give them too much fluid, we push them into fluid overload, then their lungs are going to start filling up with fluid and third spacing into the lungs. So when you listen, you're going to hear crackles. And these crackles are indicative of there's fluid in the lungs. Now, we also can have something called flash pulmonary edema. If my patient starts coughing up pink frothy sputum, that is a big sign that you need to call a rapid immediately. You need to get them into an intensive care unit because they are filling up quickly with fluid in their lungs and they're not going to be able to breathe even with a tube. Incentive spirometry, and with an incentive spirometer, we ask them to draw back on the incentive spirometer, just like they would be doing if they were smoking a cigarette. pull back slowly, and that helps to stretch the lungs and helps the lungs to expand when they haven't been expanding. We want to make sure that they're eating enough. When patients get sick, especially with pneumonia, it's kind of hard to eat and be able to breathe simultaneously. And it takes a lot of energy when you're struggling to breathe. You want to make sure that you cluster your care together, let them rest, give them activity as they can tolerate, and teach them how to do self-care with pneumonia as well. So here's an example of the chest physiometry. And so with this, we are using vibrations within the lungs, applied through a device on the outside of the chest to help break up the yuck, the mucus within the lungs. So atelectasis. Atelectasis is when we have complete collapse of alveoli. As we are collapsing our alveoli, we are losing the ability to oxygenate through those alveoli. So the collapse can happen quickly. The collapse can be chronic. One of the most common ways you can have atelectasis happens during the postoperative period. We're not moving around. It hurts to take a deep breath. So we're not taking many deep breaths. And as a result of that, the lung can simply collapse. Now, there's other ways that atelectasis can happen. We can also have like a pneumothorax or something that has caused the lung to collapse. So with atelectasis, it happens very quickly. We really don't see any indication that this is happening. All of a sudden, our patient can't breathe and they start coughing and complaining of shortness of breath, and they start producing a lot of sputum. If it happens quickly, our heart's going to react because of the problems within the lungs. So we're going to have tachycardia. We're going to be breathing fast, and this is very, very painful. And if we have a full lung that has been affected and all the alveoli have collapsed, then we also can see cyanosis. If it's a chronic atelectasis, we also can see pulmonary infection, pneumonia present. So with the atelectasis, it can be also obstructive in nature. So if something such as a mucus plug or cancer or foreign object has blocked the airway, and so you can't actually get air to the alveoli where it needs to be, then that can cause atelectasis as well. Now, non-obstructive atelectasis happens in conditions like post-op, pneumonia, anything that causes the patient to not take big, deep breaths. And that's one reason we really encourage our patients to do deep breathing. Pleural effusions, this is a very small amount of fluid that's within the lungs. So when we have a whole lot of fluid, it changes names from pulmonary effusions to pulmonary edema. So the lung, when we have fluid in place, it can't open as fully due to the pressure caused by the fluid within the lung. So this is what an X-ray is going to look like with a massive pleural effusion. So we have lots of fluid on the left side of and you can tell that by it being so opaque. So if you look at where the heart is, it has been shifted to the opposite side. So with atelectasis, you will not see the mediastinal shift that you see with pleural effusions. So to treat atelectasis, big thing is make your patients do deep breathing. To educate your patients, whenever there's a commercial come on TV, use your flutter valve, use your incentive spirometer, do some deep breathing exercises. When a patient is laying in bed, they really have no reason to deep breathe. So you want to get your patient up and out of the bed, because what happens when they're in bed? They slide down, they get all contorted, and their lungs can't open up fully. So you want to get them out of bed, get them coughing, get them moving this mucus and fluids that can get into their lungs. Get them moving, get them coughing. Postural drainage. If we're wanting to drain the left lung, we would turn them on their right side so the left lung can be drained by gravity. We also want to frequently turn them to make sure that fluid and mucus doesn't consolidate in specific areas. A pulmonary embolus is going to be caused by a blood clot. So we've talked about that as one of our big reasons and ways that people die. This is an inflammatory process. Once the blood clot is in place, swelling starts. And with this, the blood flow to get to the lung becomes obstructed. This causes the bronchioles to constrict and causes further problems down the line. So with this, we have a ventilation perfusion imbalance. You may see this referred to by medical providers as a VQ imbalance. So ventilation is the V in that, and then Q is for perfusion. I don't know where that came from, but it does get referred to as VQ testing, VQ imbalance quite frequently. If the blood is messed up within the lungs, then that's going to cause a backup within our heart. So we will start to see right ventricular problems and the blood backing up into the heart, and eventually shock will start to occur. So when we have a large pulmonary embolus, complications can be respiratory failure. Our patient can start to go into shock. Eventually death can happen, death of the lung, and then eventual systemic death as a result of not being able to deep breathe and not being able to oxygenate the cells appropriately. So there's several risk factors for developing a pulmonary embolus. First off is going to be clots anywhere within the body. We've talked about that before. Trauma can also be a reason that we would have a pulmonary embolus. Fat emboli, we've talked about those before, being released from bone surgeries and from fractures. Within pregnancy, the amount of blood that we have increases significantly, and that can contribute to the risk for developing pulmonary embolus. If our blood is too clotty, let's say a patient is supposed to be taking Coumadin and then just stops taking it or doesn't take it consistently, we have blood that is going to be more likely to clot. That good old atrial fibrillation that we've talked about before, where we lose the atrial kick because the right and left atria are no longer squeezing like they should be, that can also contribute to developing clots as well. Hemoptysis. Hemoptysis is coughing up blood. So with coughing up blood, it depends on exactly what the blood looks like. Pink frothy sputum. Please remember this, because you have got to intervene quickly because your patient is tanking and will code very quickly. Blood-streaked mucus that's not frothy is likely to have come from irritation from the trachea or bronchus. So blood without mucus is likely from the GI tract or a GI bleed or from the oral pharynx. So very important, pink frothy sputum. You need to get somebody there to be able to help your patient. They're going to be coding very soon. Different pleural conditions. The pleural space is going to be the covering for the lung. And so pleural conditions are going to be where we have a problem within the lung and the tougher outer coating of the lung. So if we have an infection there, that's called pleurisy, and we would give antibiotics for that. We'll end up with friction rubs. We'll be talking about that more in just a minute. If we have too much fluid in between the pleura and the lung, then that is a pleural effusion. If the pleural cavity has been broken in some way, we can have a pneumothorax and a collapsed lung. Hemothorax is when blood is in that place, and an empyema is kind of like an abscess within that area. It's going to have a thickened mucus within the pleural cavity. So with pleurisy is an inflammation of both layers of the pleura. And the key factor is going to be knife-like pain on inspiration. You can hear the pleura rub against each other with a stethoscope, and it can be very painful, as we talked about. So NSAIDs are what we would give for pleurisy. And we also will teach them to splint the rib cage when coughing. Use a pillow, use a blanket, something where it's hurting, splint that area, and it makes it much better. So tests that we're going to use is going to be chest x-rays, sputum analyses, etc. So with pleurisy, if it lasts for a longer period of time, we may also give them antibiotics to treat it. A pleural effusion, this is where fluid collects in the pleural space. We will often see this in conditions like TB, pneumonia, pulmonary infections. So secondary to heart failure as well, because the blood is backing up, it backs up everywhere. And so with a pleural effusion, your patient is going to have pain on inspiration, that is the pleuritic pain. They're going to have shortness of breath, and fever is going to be a major issue. Also decreased or absent breath sounds, decreased fremitus, and we talked about that in other classes, and a dull flat sound on percussion. Depending on the severity of the pleural effusion, you can see tracheal deviation. Typically at that point, it will be combined with a pneumothorax as well. So we can see these on chest x-rays. We can also see them on CAT scans. And if we go in and with a thoracentesis, we also can find it. So pleural effusion is a consequence of something else. We want to fix the major problem that's causing the pleural effusion, not necessarily the pleural effusion itself. Empyema, this is going to be an abscess within the pleural space. So this is a complication of bacterial pneumonia. It's going to be thickened, purulent fluid that has antibodies and has white blood cells in it, discolored within the pleural space. So when we are listening to the breath sounds, we will hear decreased or absent breath sounds over the affected area. Your patient is super sick with an empyema. So we often will use a chest CT to be able to diagnose it. And we will send them to have a bronchioscopy and in IVR, and they can actually drain that fluid, and they will be on antibiotics, IV antibiotics for a good long time with an empyema. Hemothorax, this is an accumulation of blood. We've talked about those before. You also are going to have reduced or absent breath sounds on the affected side, and we may do a thoracentesis to be able to help them to be able to breathe quickly. Pneumothorax is where the lung is being collapsed due to a pressure gradient. We'll see tracheal deviation with this, and we'll also hear hyperresonance when we are doing percussion due to the trapped air that's within the pleural cavity. So pneumothorax can be a simple pneumothorax, can be spontaneous. It also could be a traumatic pneumothorax. Now, some people, particularly really tall people, I had a gentleman in the hospital and he was 6'6", and he had a condition where he had frequent spontaneous pneumothorax. And they actually ended up doing a procedure on him where they went into his pleural cavity and put a substance similar to, like, think of like sterilized baby powder, that had that kind of grainy consistency, to actually act as an irritant for the pleural cavity. So when they reinflated the lung, it would actually create scar tissue in place to help prevent the spontaneous pneumothorax that he kept having. He actually was on vacation in the Great Smoky Mountains National Park when this happened. And he was from another state pretty far away, and he ended up having to stay in the hospital. He was too ill to be able to be transferred due to the distance of where his home was, until he had this procedure here and recovered. Then he was able to be put on a plane to be able to go home to his geographic area. So this is what a simple spontaneous pneumothorax looks like. The lung will actually pull away and then will just pop. Tension pneumothorax, we've talked about. It's a true medical emergency. Tracheal deviation with tension pneumothorax. So with this, you're going to see very much your patient's going to be anxious. They're going to be breathing fast and shallow, and they will have absent breath sounds on the side that's affected. So again, this image to show you the difference in pleural effusion and atelectasis. Flail chest. With a flail chest, you will have paradoxical chest movement. With a flail chest, as you are inhaling, what will happen is your lungs get bigger. That part that is broken, where the ribs are broken in two places, is going to be sucked in. Now, as you are exhaling and your chest is getting smaller, that part where the ribs are broken will be pushed out. And be sure and check out this YouTube video. It's pretty cool, from your PowerPoint slides. Acute respiratory distress syndrome. This is an emergency. This is where your alveoli get filled with fluid, and it's caused by inflammation, causing alveolar damage. And with this, we are getting progressive pulmonary edema. So what's happening is our patient can be on 100% oxygen, yet still have crappy sats. So we would see this would be the end stage of what happens with patients with COVID. We would have patients with COVID, we'd have them on 100% oxygen, still have them satting 80%. And so with ARDS, it mimics pulmonary edema for a time period, but it's not simply fluid. It's an inflammatory, purulent discharge that is actually within the alveoli. So it doesn't get out, and your patient doesn't pink up like with pulmonary edema, and you get rid of the fluid. Acute respiratory failure. This is going to be a situation where you are not breathing as you should. Acute respiratory failure and ARDS go together. Acute respiratory failure can be caused by any reason why you're not able to get oxygen in. It may be due to a problem with the brain. The brain is not telling the lungs to breathe. It can be due to problems with the diaphragm. Acute respiratory failure can be due to COPD, chronic smoking. So the oxygenation can happen like it's supposed to. ARDS is when we shift over that line from respiratory failure to ARDS, that's when our patients are in major trouble because they end up with a mortality rate of almost half. It's really, really a dangerous situation. So what is happening within ARDS? And so with this, you do not have to know everything that's going on, but we talked about macrophages. Macrophages go through and they try and clean up any kind of bacteria, any kind of things that are not supposed to be within the alveoli, within the lungs. So TNF is tumor necrosis factor. And then we also have ILs, which is interleukins. These are the chemical messengers that yell for help to activate different parts of the immune system. So what I want you to know from this is that ARDS is the result of inflammation within the alveoli, also within the blood vessels that are trying to drop off the red blood cells to pick up oxygen to carry it away. So it is a complex process that involves inflammation, clotting cascades, interleukins, and different messengers within the immune system. So with ARDS, again, very, very dangerous disorder. This is a patient that's on a rotoprone bed. And with this patient's, the patient's left side is up. So they are trying to drain the left lung to help improve oxygenation and help to get rid of that fluid. So the care tends to be supportive. We try to fix the symptoms, and there is no direct therapy. Now, when we are doing putting a patient prone, one person's job is the airway, because what can happen is that tube or the cord going to the vent can get caught on something and the patient can be accidentally extubated. Now, we don't have enough rotoprone beds, as we found out with COVID. And so with this, we will also prone people in regular beds using different methods. Medications that we'll be using in ARDS, we'll be giving benzodiazepams. This is going to decrease the fighting of the ventilator. What happens when somebody is fighting a ventilator, they try to go against it. And it's really, really hard work on their lungs. It increases the stress on their lungs. So by giving a benzo, we reduce anxiety and we decrease the oxygen consumption because they're not fighting the ventilator. Corticosteroids is going to decrease inflammation, and it helps to slow down the white blood cell migration to the area, which contributes to the inflammation. Antibiotics, we want to get rid of any bacteria that's there that's not supposed to be there. And then we've talked about before morphine. Morphine has that side effect of reducing air hunger. So it is a very good pain management choice for the patient with ARDS. Now, we've also mentioned in this the ventilation and perfusion VQ match. So ventilation, I have to be able to breathe and get oxygen in. Perfusion, I have to be able to get that oxygen onto the red blood cell and it be carried throughout the body for the cells throughout the body to get the oxygen that they need. And this is just another demonstration of what is happening when there's a VQ mismatch. Now, this picture is a lot easier for you to see what's happening. When you have alveoli that aren't getting oxygen, poorly ventilated, okay, they aren't filled up with air. And so that blood that should have gotten oxygen from that alveoli Instead of being bright red, it's now a purple color because it's been mixed with poorly oxygenated blood. So what happens overall is the oxygen saturation within the blood has now dropped because your patient has problems with ventilation, and so they have a VQ mismatch. Now, the other way this can happen is if we have physiologic dead space. So what this means is no blood flow. Notice our oxygen levels have been cut in half because one of these alveoli, we're ventilating well, but we're not perfusing because we don't have the blood flow picking up the red blood cell, giving it oxygen to be able to take to the rest of the body. So an area with ventilation but no perfusion is called a dead space. Okay, an area with perfusion but no ventilation is called a shunt. So this is an example of dead space within a pulmonary embolism. So our embolus has blocked the vasculature. So we're getting air into the lungs, we're getting oxygen into the lungs, but it can't get onto the red blood cells, so it's not being taken out to the body like it should be. A fibrous lung, pulmonary fibrosis. With pulmonary fibrosis, the most common kind that we have is called an idiopathic pulmonary fibrosis. And with idiopathic pulmonary fibrosis, we have a thickening. That's what fibrosis means. We have a thickening within the lungs, so the lungs are not as compliant as they should be. As a result of that, our patient's going to have a dry cough. They're going to have shortness of breath. It's a whole lot of work to be able to breathe, so they're going to have weight loss as well, and they're going to be exhausted all the time, just simply due to the work that's required to be able to breathe. Pulmonary hypertension. This is where we have too much pressure within the lungs, within the pulmonary circulation. So with pulmonary hypertension, our right ventricle is having to push too hard against the pulmonary vasculature to be able to push the amount of blood through that needs to go through. Normal arterial pressure within the pulmonary artery is between 12 to 15 millimeters of mercury. So when we have problems with just the vasculature in the lungs, it's called pulmonary hypertension. Now, one of the ways that we treat this is actually with sildenafil, better known as Viagra, phosphodiesterase inhibitor. And that will help to decrease the constriction that's happening within the pulmonary artery. We measure it indirectly through echoes. We can do that through a regular transthoracic echo, a TTE, or we can do it through a transesophageal echo, a TEE. We also can see evidence of congestion present on a chest X-ray, and if left long-term, this will result in right ventricular failure, which is better known as cor pulmonale. So you can see cor pulmonale and changes with your P wave and your PR interval. That's not going to be on the test. Cor pulmonale is going to be a more advanced thing to be looking for on EKGs. And pulmonary hypertension is often secondary to something else. We'll see pulmonary hypertension in cases of a pulmonary embolus. The pressure increases trying to force that blood through. We also will see it with mitral valve disease and COPD and ARDS. Okay, guys, thank you very much for listening. I will see you in class later. Bye.